Hello and welcome to the Unit 3 presentation on verbal communication. These are some of your learning objectives for this unit. The remainder are listed on the documentation presentation, and the complete list you can find in E360. The standard process for communication in healthcare is with the use of SBAR: situation, background, assessment, and recommendations. Using SBAR is important to prevent miscommunication among the healthcare team. SBAR is especially important if you are communicating with a provider that does not know the patient. The details you give help them form a better picture of the patient's problem and how it should be treated. Be sure to fully understand SBAR. You need it for the test and also for your career as a nurse. There's a handout in E360 with a sample SBAR. Additionally, this slide shows an example of a home health nurse calling the patient's physician with some concerns using SBAR. Please pause and review the SBAR communication. Therapeutic communication is an essential part of the nurse-patient relationship. This includes both verbal and nonverbal communication. A few things to consider are pacing. Speak slowly and enunciate clearly. Intonation. Your tone of voice affects the meaning of the message. For example, a patronizing tone or being condescending changes the message. Clarity and brevity. Keep communication simple, brief, and direct. Less words equals less confusion. You know, and okay detract from the message. Timing and relevance. Poor timing will result in poor communication, so if your patient has pain or is overly emotional, this may need to be addressed first. Look to the patient for cues. For nonverbal communication, think about personal appearance, such as physical characteristics and facial expression. Posture and gait, like leaning forward, conveys attention. A slumped posture may show fatigue. Facial expression. The face is the most expressive part of the body, you know. Try to avoid showing shock and dismay. The patient may be thinking, am I going to die? And you need to maintain a neutral or positive face so that you don't scare them even more. Eye contact. Lack of eye contact could be anxiety, defensiveness, discomfort, or lack of confidence. However, there are some cultural considerations to think about. Some cultures view eye contact as rude or disrespectful. Gestures may be used to emphasize or clarify spoken word. Sounds such as sighs, groans, and sobs also should be considered. Personal space. Think about how close you want people to be to you, and remember to respect a patient's need for personal space. Closeness to a patient depends on whether you are completing a physical assessment versus taking a patient history. Meta-communication includes all factors that influence communication when verbals and nonverbals don't match. So the pre-interaction phase of a helping relationship is when you review the data, medical and nursing history, talk with other caregivers about the patient, anticipate health concerns and issues, and identify a location for private interaction. Also be sure to plan enough time. The introduction orientation phase sets the tone of the relationship. The initial relationship is often superficial, and the patient will test your competence. Observe the patient, but also expect to be observed yourself. Make inferences and judgments about witness behaviors, and assess the patient's health. Prioritize problems and clarify the patient's and yours roles. Lay out expectations and let the patient know when the relationship will be terminated. The working phase is where there's an exploration of feelings, information is provided by you and the patient, goals are set, the nurse uses therapeutic communication, and sometimes self-disclosure and confrontation if necessary. Termination is the last phase. This is where there is closure. Remind the patient that termination is near. For example, say, I'm here till 6 p.m. and then I will give report to your new nurse. Evaluate goal achievement and separate from the patient by relinquishing responsibility for his or her care. Achieve a smooth transition for the patient to other caregivers. So introduce the oncoming nurse, and evidence-based practice recommends, just so you're aware, a bedside report handoff to minimize errors. And actually, many facilities are requiring the bedside handoff. A primary nursing role is to advocate for patients. Sometimes this conflicts with provider viewpoints. An example is if a provider sees a terminally ill patient is in renal failure. They may suggest to the patient's family to start dialysis. As a nurse, we need to think about the end goal. Perhaps the patient has said they don't want heroic measures. Is dialysis a heroic measure? Would the patient want this? Or is it going to change the patient's outcome or just cause suffering? These are things to discuss with the provider as a patient advocate. Often the provider may get caught up in saving lives and does not think about the quality of life as interpreted by the patient or the family. It's very important to develop a rapport with our patient. This allows them to trust us and get the most out of the nurse-patient relationship. Physical attending is one way to show the patient that we're interested in what they have to say. Remembering and using the acronym SOLAR is a good way to do this. Attentive listening, or paying attention to the whole person and total message, both verbal and nonverbal, content and feelings, is a crucial skill to develop. This allows us to treat the whole patient. Remember those 3 domains of nursing for holistic care from week 1? We need to apply them here. This chart is from your text. It lists a variety of therapeutic communication techniques. Be sure to know and understand how to use these. We will be doing a process recording in this class, as well in nursing clinicals, as practice with therapeutic communication, so it will be important to understand what each of these are. Non-therapeutic communication is communication that puts up barriers or blocks to the patient exploring their feelings. Some examples are listed here. It's equally important to understand and to be able to identify non-therapeutic communication for the process recording, both in this class and in clinicals. When communicating with patients with special needs, there's a few things to keep in mind to make the process more effective. Make sure the patient knows you're talking. Face the patient with your mouth visible and no chewing gum. Speak clearly, but don't exaggerate lip movement. Speak slowly, but not excessively slow. Make sure the patient has appropriate assistive devices. Choose quiet, well-lit area. Allow time for the patient to respond. This is especially important for those with difficulty getting their thoughts out loud. Allow the patient time to ask questions. For non-English speaking patients, assess the patient's primary language and English skills and provide an interpreter if necessary. Remember that nodding does not indicate understanding. Provide written information in English and the patient's primary language. Learn about different cultures in your area and remember to understand your own cultural biases. So to recap, be sure to answer that you're able to answer the bullets on this slide. We talked about some therapeutic communication techniques, and we also talked about some blocks to therapeutic communication that can have a negative effect on your interaction with your patients. That concludes this presentation on communication.